All right, we are live here at the first Tuva community meetup. Welcome, everyone. This has been a long time coming. We've kind of been like heads down building for quite a while, but excited to kind of kick off our what we think will be a kind of a monthly community meetup series. We're also kind of thinking about having starting some like deeper dive workshops that are kind of ongoing and more specific to certain topic areas. For example, like medical economics, like risk adjustment, like clinical quality measures, things like that. So your feedback is what inspires us to do what we do and informs really the direction we take. So we love all feedback from the community. My name is Aaron Niederheiser. I'm the CEO and co-founder of Tuva Health. We've got the focus of the meetup today is really going to be on a medical economics topic. We're gonna walk through. It's an area we've been building in for a while, and specifically, we're gonna walk through some of the things we've built around service categories and encounters. And you're going to hear from the folks on the team who actually built those things. Tom, if you wouldn't mind going to the next slide for me. Here's kind of you can kind of see our rough agenda here. I'm going to do a little bit of an intro and just share some really high level kind of like product roadmap updates. And then I'll turn it over to Tom and Brad, who have done a lot of the engineering behind the service categories and encounter groupers, and we'll just get into it and we'll have a good discussion around it. This is intended to be very kind of like informal, and really how we think about it is like we're just trying to get to the right answer here. We're trying, like, if a great objective would be like everyone, like the more people walk away learning something, the more interesting that is. That's how we like move the ball forward. And if that means we discover that we've built something in a way that is wrong, or we get some ideas about how to improve it, that's like the most exciting thing. And so there's no, we like really check our egos at the door. We're like just very focused on like getting to the right answer. And I think one of the best ways to do that is like healthcare analytics is everyone in this industry has so much institutional knowledge that's trapped in our heads. And so we're trying to like facilitate a way where we can like bring all that knowledge out into the open and everybody can benefit from it. Next slide, Tom. Just like some, like just very like high level, like how did we get started? How did Coco and I started Tuva 3 years ago? After we've both been in healthcare analytics basically our entire careers since getting out of academia. And like, why did we do this? If you're not familiar with kind of our story around how we got into this, there were basically like every healthcare organization that we worked at and every healthcare data team that we worked with or saw, we're always doing two things. We were like building and rebuilding the same tools over and over again. And we weren't really having like open discussions around like what the best way was to build these tools. Whether it's like designing a certain like data model to do something or building a certain methodology to do something like assign patients to a certain type of provider. And usually that was because we often just didn't have enough time to do it. We were always like running to like trying to crank out analytics and moving from one thing to the next thing. And so these are kind of the two main problems that we're trying to solve with Tuva is how can we kind of like put stuff out there that is reusable? And then how can we create a community that enables us to like have discussion around these things so that over time we can get to the best answer. So that's kind of a little bit about the founding story and like what we've been working toward. I'll just touch briefly on kind of where our focus is from like a product roadmap standpoint. If you want to go to the next slide, Tom. I'm just realizing this text is a little small. Sorry about that, at least on my screen. There's kind of like, I mean, for the last several years, we've been 100% focused on building out the open source, the Tuva data model, everything that goes around it. And there's like 4 areas that we are really working a lot in now, and we're going to continue to really build a lot in. I'll just touch on each of these quickly. The first being medical economics. This is really like, you know, medical economics is kind of a loaded term, but really it comes down to like really typically focused on claims data and how do I analyze claims data to identify how care is being delivered to certain patient populations and how it could be delivered maybe more efficiently from a cost, utilization, quality, or outcomes standpoint. And so doing a lot of medical economics requires a lot of groupers, right? You need to tag claims, medical claims, pharmacy claims, tag providers, tag patients, do things like attribution, just so that you can get to the point where you can build dashboards or do analyses. And so obviously service categories and encounters are a subset of those groupers. But this is like there's actually quite a bit to build here. And we've got we'll actually post a video kind of summarizing our approach to building here in the next couple, what we're going to be doing with medical economics in the next couple of days. But this is going to continue to be a big area of focus for us, you know, for the next several years and beyond, basically. Risk adjustment is another one. So to date, we've released a few versions of the CMS HCC risk models, the V28, the V24. We've also released HCC suspecting on CMS HCCs. And you can kind of go read about how we do those methods. There's a few methods for that, but there's just a ton more to build here as well. We need to build out suspecting there's like, you know, several dozen more conditions that we need to build out suspecting on. And there's several more risk models. And we know that folks in the community have really been utilized. This is the risk adjustment category is kind of a main thing that folks have been utilizing. And so we'll continue to build out there. The connectors are just, a connector, if you're not familiar, is like how you transform any raw data set into the Tuva data model, right? It's basically like SQL code that will map from like a data set like Elation's backend medical record system or CMS CCLF data into the Tuva input layer, which is like really the first layer of the Tuva data model. Once data is in the input layer, you can build the rest of Tuva by running dbt build from the command line. And so we'll continue to publish. We've got about a dozen connectors that we're going to be publishing in the next couple of months, both claims and medical records, and also some additional FHIR and ADT connectors. These are really intended to be sort of starter sets. So it's not really like it's going to be perfect, because if you've seen one that, like, for example, we've done several implementations of Athena, the EMR system, for organizations that have asked us to set up Tuva for them, and there's differences across the versions that we've set up, and so like I think basically that's going to be the case with most connectors for most data sources. Is, you know, Aetna probably has a couple flavors of claims, but even within those flavors, there's variation over time. And so, but hopefully by publishing the connectors, we get folks, you know, 80-90% of the way there, and there's only a few tweaks that you have to do. So that's kind of the thinking on that. And then the last one, data quality audit. this has been a long time coming. If you've been on our docs site, the tuvaproject.com, we added a section called data quality, where we really describe our kind of philosophy and approach for doing data quality. And we've built a lot of stuff into the Tuva data model that's data quality related over time. But in the last few months, we've really focused on developing what we're kind of calling our standard data quality audit process. And I'm super excited about this. But basically, what this is trying to do is if give you a tool that if you're mapping a data set to the Tuva data model, that you can automatically run this tool, and it'll basically tell you, did you do that mapping correctly, or where are the problems, and what is the impact on the analytics that you can run out of the box. So like, it's not, the tough thing with data quality and healthcare data is the more you look, the more problems you find. Like, there's almost an infinite amount of data quality problems. And so that's not what we're trying to solve with this. We're trying to really take here's the most important stuff that you need to make sure you got right when you map a data set. And if you didn't map something right, here's what it screws up. So here are the key fields. Here's what needs to be right about the key fields. Here's all the data marts. Are the data marts populating? Here's the analytics that you can do out of the data marts. Do the analytics make sense? And we've built all this into a Streamlit app, which is kind of like a, I don't know how to describe it. It's sort of like a notebook style. It's not really a notebook, but it's sort of like it's something that you can run from your local machine. Just like you can run DBT and connect to your data warehouse from your local machine and do DBT build. This will be something that you can also connect. Yes, thank you, Joe Warbington. That's exactly what it is. And the good thing about this is you'll also be able to it'll basically give you sort of a report that'll show you all these problems, and it'll be easy to share across your team as well. So that's what we're really focused on the open source side. And then we've also started working on some closed source software that will sell starting in Q1 of next year around the open source data model. And so this is really solving challenges. Our thinking is we build this open source data model that has all these concepts built into it, so that we're not reinventing the wheel, but there's still problems to solve kind of around that. And so we're starting to roll out software that solves particular problems around the data model for doing advanced analytics, or for if you're really trying to build your data platform on Tuva. And so the three things that we're rolling out are Master Patient Index. So this is, if you're not familiar with Master Patient Index, if you're putting let's say you have multiple data sources that you get, like you have a medical record system, a couple claims data sets, maybe you get a fire data feed, and you have the same patients across those data sources, but you don't have a unique patient ID across those data sources, you won't be able to do analytics across those data sources. And so Master Patient Index is basically a tool that uses patient data, like first name, last name, date of birth, to create a unique ID so that you can do cross data set analytics. Like pretty much any of the things we're building, we're not building anything new. But there's many other vendors you can go buy Master Patient Index software from. But the way we're building each of these things is that they're very tightly integrated with the Tuva data model and the Tuva stack. So if you bought Master Patient Index or any of these things from another vendor, you'd have to kind of figure out all the data pipelining and integrate it. And we're building these things to be very tightly integrated. So it's kind of like turning on a light switch to deploy and manage these things. So that's Master Patient Index. NCQA certified HEDIS measures. I think everybody probably a lot of people will probably understand what that means. NCQA HEDIS measures are table stakes for lots of healthcare organizations from a quality measurement standpoint. They are obviously the certified versions of those measures are like, copyrighted measures. And we are working on entering into a partnership with NCQA where we can offer all roughly 80 NCQA certified HEDIS measures out of the box if your data is in the Tuva data model. So normally there's like work to like implement the engine and certify the measures and like lots of data pipelining and similar to master patient index, we're working to make that kind of like turnkey, just flip the light switch kind of on the Tuva data model. And then the last one here being benchmarking. This kind of goes hand in hand with a lot of the medical economics work. Oftentimes in medical economics, you're trying to like identify efficiencies or where you're less efficient in terms of how you're delivering care to different patient populations or care settings, et cetera. And oftentimes, that comes down to like, okay, like, am I doing good or bad? Well, compared to what, right? And so benchmarks are just kind of like a very helpful tool for doing that. And again, like any of these things, like there are lots of places that you can buy benchmarking from in healthcare. All of this is based on like any organization that does this is basing it on like, large national all payer data sets of de-identified third-party data that they've purchased. We're working out some data sharing agreements to be able to access similar data sets, and that's what will power our benchmarking. The difference here again is just the integration with the Tuva data model. And so, if you're using the Tuva data model to do some analytics and you need a benchmark, you probably want that benchmark computed using the same methodology. So your comparisons are apples to apples. And so we'll be rolling out benchmarking that enables that. And again, it's kind of like easy to turn on if you want to turn that on. So that kind of concludes the high level, like kind of where are we going, what are we building, and obviously I'll say it again, like we highly prioritize based on feedback that we hear from the community. Either like I get, I talk to folks in the community every single week, either DM or like meetings, like just coffee chats. So if you are somebody that wants to give us feedback, feel free to like throw that into like a channel like Builders Ask if you have an idea, or if you want to like just like send me a DM, that's fine too, and we love feedback. I am going to try and moderate the questions a little bit, especially as Tom and Brad take over. It's hard to talk and moderate questions at the same time. One question from Peter. Do you have timing published anywhere for both the open and the closed source projects? No, why would we do that, Peter? Good idea. So we actually don't, but we should. I'll just give you a quick sense of when some things are coming. The connectors, several of those will be coming out in the next, roughly before the end of the year. I would say we'll have probably between a half dozen and a dozen new connectors out before the end of the year. You can look on the GitHub issues backlog to see some of those. The data quality audit, we are aiming to do a release of that, including the Streamlit app, before the next community meetup. And we're actually thinking that that'll probably be the focus of the next community meetup, is kind of like diving into that. And then medical economics and risk adjustment. We've got a bunch of things we're working on in those buckets. We'll share more specifics on those things. For the closed source stuff, master patient index, we're targeting releasing V1 of that on January 15th. It probably won't be generally available until a couple of months after that. So stay tuned for more info on that. NCQA, we're targeting February 1st, and we're targeting that for GA. And then benchmarking would probably be closer to the end of Q1. So that's the short answer on timing for those things. All right, enough of me talking. It's a sickness. I apologize. I can't shut up sometimes. So with that, I'll turn it over to Tom and Brad, and I'll try and moderate stuff if I see questions. But we can keep it super informal. It's not supposed to be super polished. So, Tom and Brad, take it away.
Yeah, thanks, Aaron. Hi, everyone. Good afternoon or good morning, depending on what time zone you're in. I'm in Michigan, so I'm in the afternoon here. Just a quick background for me, and then Brad, and we'll jump into encounters and service types. So I've been doing healthcare data analytics for about 10 years now. Prior to that, I did a master's degree in healthcare administration at the University of Michigan, go Blue. And had some stops in consulting, Intermountain Healthcare and their Pop Health Analytics group, Health Catalyst, and I've been at Tuva since about February of this year. Yeah, I think that's probably it. Brad, do you want to do a quick overview as well?
Yeah, thanks, Tom. My name is Brad Montier. Pretty similar background to Tom's. I've been at Tuva since February of this year, so about 9 months now. And prior to that, I was at Health Catalyst, where I worked on the Value Optimizer product, which is their population health value-based care product. I'm really excited to take a lot of the learnings, the proprietary closed source types of things that we worked on there and bring that knowledge here to Tuva and share it in the community. So yeah.
Thanks, Brad. As Aaron mentioned, just as we get started with this, we've got a couple slides set up, and I'll jump back and forth between some of the slides, Excel and Power BI, as we kind of talk about how we developed these and how they work. So all that to say, like, this can be much more of an informal discussion than like a lecture or presentation. So I don't know how exactly we'll all work that out with so many people, but feel free to raise your hand, or since Aaron's moderating, put a question in chat. If you're not on our Slack community, please join Slack. If we don't get to one of your questions, you can DM myself, Brad, Aaron, any of us, or post questions to the general community as well. So that'll be a great place to follow up if we run out of time in our conversation today. So I'm not sure what everyone's background is, where we're all coming from as far as claims data knowledge, analytics knowledge. And so I wanted to start us off with just what even are claims groupers and why do we use them? Why are they important? And they can be at all kinds of different levels across claims data analytics. But essentially what they're trying to do is they're algorithms that provide a categorization of claims to be able to integrate and standardize different data sets, as well as provide a basis for analysis and reporting. We've talked about medical economics a couple times already in the presentation. The goal of that is really to be able to understand the cost and utilization drivers of a given population based on their claims data in a way that can reflect either like pricing models or operations or some other way to have these groupings that make sense and help us better understand what's happening with our population and how they're utilizing healthcare services. There are companies out there like Milliman, Optum, 3M that all have proprietary black box claims groupers. And the goal, like Aaron said, of what we're doing here is trying to open source that industry knowledge and be able to, as a community, build some really effective, powerful groupers to be able to do this analysis and open source it so you can load your data and have all these out of the box with the Tuva project. We currently have a couple of different claims grouping algorithms built into the Tuva project. The first one is actually sort of inherent to the claims itself, the claim type. In the Tuva project, we primarily just use institutional claims, professional claims, and then there's also another table for pharmacy claims. You could expand that to include things like DME or dental or vision, could potentially also be additional claim types. And when I think about claim types, it really helps me, just with the way my brain works, to go back to the paper forms and think about what forms would they come on, whether it's the UB04 or the CMS 1500, and then what fields are unique to those forms. So when we talk about claims type, it's a really high level, just was this from a facility? Was it from a professional provider or APP or something like that? The bulk of our conversation today is going to focus on the next two claims groupers that Brad and I put together over the last couple of months and have released in the current version of the Tuva project, and that's service category and encounters. What service categories do is they go through each claim line item and each claim and categorize based on a couple of different fields what services were incurred for that specific line. So you have things like labs and DME, or an outpatient visit, or an office visit with a professional from a professional claim. In most cases, these are done at the line level, but in some cases, they get rolled up to a claim header level. Most of the time, that's the institutional claims for like an acute inpatient visit, for example. Then encounters sit on top of service categories, and we use the service categories to help us build the encounters and identify anchor events that we need to group other claims into. And so we're going to walk through an example of that using an acute inpatient encounter. As Aaron mentioned, we're going to be working on additional claims groupers over the next couple of months, including things like episodes, bundles, trying to answer questions like what conditions did the patient have, what was done, by who, and where. And these will fit into medical economics types analyses that we'll be able to do as well to sit on top of these other claims groupers, or in some cases alongside them. So this is the story of a claim. I want to walk through just a quick example, and we're going to do this in kind of a narrative format, but I also have this in Excel where we can actually look at the claim lines to show what this would look like in a data set. It's just a synthetic claim example, so there's no PHI or anything like that. Just kind of a general, we see this type of encounter all the time. And so that you can, if you're not familiar with it, you can kind of see what we're looking at and how an encounter grouper would sit on top of a service grouper or service categories, and what fields are really critical to be able to make those work effectively with the way we've currently built it. So let's say in this hypothetical example, we have a John Doe. He enters an academic medical center emergency department. He has a fever, tachycardia, shallow breathing. In our claims data, what we would see from this encounter is a professional claim with a service code 23, and then some HCPCS codes that might be, you know, an ED, E&M visit, maybe some lab test or something like that to figure out what's going on. And our service counters would assign these as an outpatient emergency visit service category. And then that would actually also, in this case, become the encounter type. So if we just had a couple of lines and that was the universe of what we had, this would actually be an outpatient ED encounter and service category. So let me jump over to my Excel. So if we had that, and Brad, maybe you can let me know if I need to zoom in some here.
Yeah, do you want to zoom in a little bit? That'd be helpful.
All right. Oops.
I think that's great.
Okay, thank you. So this is a pivot table. I'll bring in some of the other claim lines as we continue going through this. But basically what we've got here is a claim start date on 10/31. We see it's grouped as an acute inpatient encounter. Ignore that for now. That's the final grouping. But if we looked at just the service categories here, 1 and 2, we see that outpatient emergency department. And that's because we have a place of service code of 23, which is an emergency room hospital. If you're not familiar with those are on professional claims and indicate where the services occurred. We don't have some of the institutional fields like bill type codes or rev type codes. And then we've got, I think one of these is like a lab test or maybe EKG or something like that. And then there's an ED, E&M visit, HCPCS code or CPT code here. So if this is all that came through, this is how those groupers would handle this claim. We'd get that outpatient ED based off of those fields. If we then received additional claims or had additional claims in the extract, we might see something like this, where the John Doe was actually admitted with an initial admitting diagnosis of sepsis. When that happens, we'll see an institutional claim if there isn't one on the ED, and to categorize it as an acute inpatient encounter, we look for things like bill type code, MSDRG, and that then becomes the anchor event for that encounter that all of our other claims relative to that encounter are grouped into to create that total encounter. So in our Excel, what we would see there, and this is going to expand a little bit more here, so give me a second to orient this. So what we would see here is on that same day, that 10/31, or perhaps the following day, depending on when the ED visit occurred, right? If it was like a midnight thing, we'll get some institutional claims like what we've got here. And those are grouped into, at that point, an acute institutional inpatient encounter. And on the institutional side, like I said, we'll look for bill type codes of it being a hospital facility, so a 11, and then the last number doesn't matter in that case. They have a couple different numbers for the different types of inpatient claims there. We'll start seeing rev codes where we can see what sort of lab and tests were done. We'll also look for like a room and board. For example, you could look for that. And then we'll also have our DRG code. In this case, it's sepsis. And this, as I mentioned, then becomes the anchor claim or our anchor event for our start and end dates for our encounter type. So what we want to do then is be able to say, so this person was in an inpatient, they were admitted to the hospital. And in this example, they were there for, I think, 11 days, 2 weeks, something like that. And what we want to be able to do is algorithmically assign all of the claims that happened during that stay to the exact same encounter ID, so that that can then become the unit of analysis to understand what happened and have everything rolled up into this one bundle of care around this acute encounter. So if we jump back to our story here, what happens is we'll see on that institutional claim, we'll see an admit date and a discharge date, and that gives us our window. And then oftentimes there will be a bunch of additional professional claims that come in between those dates. And ideally, if you want to get into like physician practice optimization, your physician should be billing at least an E&M code every day, right? That's one of the things you can look for, is we want to see place of service 21, acute inpatient facility, and then an E&M code. In this case, you know, a HCPCS 99232 is, I think, subsequent inpatient care. So you would expect to see that billed every day, and you have all these professional claims that have all their own claim IDs and all that stuff. And so we need to tie them back to the encounter. So in Excel, in our data, what we would see then is on our subsequent inpatient days, because they were there for, you know, I think, like I said, in this example, I did like almost 2 weeks or something. So every day we see at least a professional claim that's categorized as acute inpatient. And the reason for that is the place of service code is 21, inpatient hospital. And then if we go over to our HCPCS columns, we're seeing at the very least some of those subsequent hospital encounter E&M visit codes that the hospitalists are billing. Then finally, what happens is we get to discharge. And the discharge date is set on that institutional claim. You've got your admit, your discharge date. So that closes the window for the encounter. We do check for the discharge status, where they were discharged to, and we make sure that there's not an overlapping inpatient stay at the same facility where you'd need to stitch the institutional claims together and actually extend those windows. That happens sometimes if there's additional institutional bills. In this case, there wasn't. And so that discharge date is set based on the initial institutional claim, and then that encounter is closed. And if we go back to this institutional claim here, I think actually I need to add, let's just do this right up front here. So this will have my admit and discharge date here. And so that's my windows of what I'm tying everything back to, so that all of these claim IDs are a part of the same encounter ID. And then we've got that, if we want to look at sepsis, right, we can look at all of our sepsis encounters. And we can even then do things like, well, what % of them were admitted via the ED, and start to analyze our data in that way. And so when you understand that at the low level, well, what does it look like to roll up to the type of dashboard that I was talking about, a type of analytics where you're looking across your entire population? And so actually, let me go a little slower here. So if you're not familiar with our docs site, the tuvaproject.com, a couple weeks ago, we launched a new section called Analytics. This is our analytics gallery. We've got a couple of Power BI dashboards out here that you can click into and look at to explore out of the box some of the different use cases that we've put together for what you can do with data from the Tuva data model. And so I'm going to go into our cost drivers dashboard, which highlights these encounter types and service categories and what they would look like on a patient population. Don't focus too much on the specific numbers in this dashboard. This is all synthetic data, and so there's some oddities that we've seen and know about that it might not make sense from a numbers perspective. But from a category perspective, what we're doing here is we're looking at 1 year of data for this population, and we're splitting our utilization out by our different encounter types. So the bold category is an encounter group, and within a group, you've got different encounter types. So we can see the different types of inpatient encounters, office-based visits, other, and then outpatient is where you'll find your ASCs and your EDs, for example. The other table here is our service categories. So if we wanted to look at a specific service category and see what types of encounters those roll up to, you could do something like just clicking on lab here and see that we've got lab services done in a number of different outpatient categories. We've got some lab services that are orphaned, which means those claims didn't roll up to any other encounter type. And then the inpatient labs would be rolled up into our acute inpatient encounters. If we want to look at just one category, so acute inpatient, since that's what we walked through, we can do some flags and analyses on our inpatient encounters to see what % of our encounters had these different the categories that we've flagged, like I talked about. So what % of them came through the ED, what % had an observation, DME, lab, pharmacy, etc. And then we can drill into those encounters to look at specific, these are all of the encounters that roll up to our acute inpatient encounters. And we can get additional levels of detail here where we can look at a specific encounter. So I'm going to pick on this one. So we've got this encounter, and we can then drill down into essentially the claim ID and the claim line number level. And we can see how this is stitched together. In this case, it was an ED visit. It's a little funky that this shows up as the acute inpatient here. This is just the synthetic data. But if we wanted to look at the dates there, we can see that. We can see all the different claims that were stitched together, as well as some of the charges and services that were incurred for that specific stay. So that's kind of like a top down into what we talked about, whereas the narrative story was kind of in the weeds and back out of how we're getting these different groupings, and then some of the different types of analyses that you can do with them. One of the things that's really cool with the Tuva project that you can do out of the box is that you can then start to ask all kinds of interesting questions about chronic conditions. So we just bumped that up in this filter here. So if you wanted to look at heart failure, for example, you've then filtered all of your claims to look at the encounters and service categories for all of the patients that had a heart failure diagnosis code or condition in that time period.
Just to jump in, oh, Rohan has a question.
Yeah.
Let me read Rohan's question. Although not the same, have you considered adding some capabilities of bundles which would apply to more outpatient office visits?
Yeah, great question. So bundles are definitely something that we want to add in the future. I mentioned that in the beginning as one of the future claims groupers, and we've done that before actually. Brad and I have, where you look at an anchor event like an acute inpatient encounter or like an outpatient surgery. And the bundle then takes a step back and goes beyond just, it groups different encounters together, right? So if you're looking at hip replacements or knee replacements, those are services that often get picked on and are starting to move from an inpatient setting to an ASC setting. So a lot of people want to track that, look at BPCIA type stuff. And so what you would do then is you'd look for that initial anchor encounter where the hip or the knee replacement actually occurred. And then depending on your specific logic, a lot of times it's 90 days, right? So you set a 90-day window, and any claims that are incurred in that 90 days post-op would all get rolled into that hip or knee replacement bundle. And so it's another higher level, right, above an encounter type. You're grouping those encounters together into the bundles. And yeah, it's a really useful analytical grouper that we'll be working on adding as well in the future.
I've also got a second question here. This one from Caroline. Caroline asks, for labs, radiology, and other ancillary services, how are you rolling them up if they did not occur on the same day? DX code, especially for outpatient office visits?
Yeah, that's a great question. I can take this one, Tom, if you want.
Yeah.
So, yeah, and if you actually jump back over to the analytics view, if we've got that pulled up here, the way that we've created these encounters is that by default, if a lab occurred during some other encounter type, then it's just a flag on the encounter, and we can kind of show the SQL how that exists. But on the core encounter table, there's just a column that's lab, yes or no, right? Binary. If we're not able, like, and we are just using date of service if it happened between the start and end dates of the encounter there. If we're not able to tie any of those to an anchor encounter, then what we've done is we've just created its own category, lab-orphan, meaning we see it in the data, but we weren't able to tie it based on dates to anything else, so we just created its own encounter for it. It's kind of how we're thinking about that right now.
Another question, this one from Serene. Do you have a list of anchor codes for various events like knee surgery or maternity?
Yeah, another great question, and actually where we were going to go next. So let's just jump right into that. On our docs site, we've got all of the different codes and value sets that we use to flag both the service categories and encounters under the docs. So actually just go back to data marts and click on service categories. And here we kind of outline from a high level, what are the, what's the total universe of service category 1, 2, and 3. And go ahead and scroll down a little bit. And so, for example, we've got the service category level 1, which is very high. It's inpatient, outpatient, office-based, ancillary. Level 2 is kind of the one that maybe most people are familiar with and that we were showing before, which is like acute inpatient, office-based. And then level 3, we only have for a few of the categories where we needed a little more detail. We wanted to drill into office-based radiology, for example, and say, oh, how many of those were MRIs, how many of those were CTs? Then we've broken out and created a third grouping there. And so this table just kind of summarizes that from a high level. But to answer your question, if we scroll down to the sections, and we look at, if we pick one, like let's do emergency department under outpatient. Here's where for every single one of these categories, you can click on it and expand it. And we've listed whether it was just a list of revenue, HCPC, place of service, DRG, whatever we use to flag and create that service category. We've gone ahead and listed it here. And sometimes it's just a list. Other times it's from a grouper like the NIDOS imaging grouper, or some of the CCS HCPC groupings. Just a few off the top of my head, but here's where we list all of that information.
That's awesome. Thanks, Brad. I thought of 2 comments, and then I'll turn it back to you guys. But one comment just on the synthetic data that's in the Power BI dashboard that we're looking at. That's CMS's new synthetic claims data set, Medicare claims data set. It's actually not terrible. It's pretty. If you need synthetic data, it's definitely worth checking out. I think we're working on a way to make it easy to run Tuva on that particular synthetic data set in the future. So I just would recommend that. It's a big step forward over like the old synthetic data that CMS published like in 2008. If you're familiar with DescendPuff, the de-identified synthetic public use files. And then a second comment is all those dashboards in the analytics gallery, we're open sourcing those as well. So much of our focus is actually in the data layer, right? The data model and all the concepts and the methods and value sets around that. But to illustrate the power of it, we really need to like build kind of these example dashboards and that tell more stories about how to use it. So that's what we started to do in the analytics gallery. There's a GitHub repo on our GitHub that has the actual files for those dashboards, so that if you want to use them if you're running Tuva, you can just run those. And we're not like necessarily married to Power BI. That's just a tool that we like and we know how to use. But like I mentioned earlier, the data quality audit is going to be in Streamlit. And I would just throw it out to the community. If you are building any sort of analytics that you think is interesting or powerful, that tells an interesting story that you think other people would benefit from, DM me, and we would love to add that to the analytics gallery. It doesn't necessarily have to be in Power BI. Okay. And just one more thing back to sorry, I told you guys I was a talker. Back to the Power BI dashboard, the specific tables that was built on, I believe the middle section is just built directly on core.encounter for the most part, and pulls in member months for some of the denominators. And so that's like actually very quick kind of to pull together. And then the table on the right is, I believe, built on core. Medical claim. And is also like fairly, or maybe it's PMPM, but one of the tables right out of the box. So,
yeah, I think there's 4 tables behind this. I put it together in a couple hours. It was mostly select star from Tuva project tables. So yeah, it's medical claim with some info from core.encounter, and then the core member months table as well. And then if you want to bring in something else like chronic conditions, then you would just join that MARDIN. So it's pretty easy to put something together like this pretty quickly.
Cool. All right, back to you. We are running short on time. I think we got 7 minutes to wrap up, but however best we can make use of that.
Yeah, I think the last thing we were going to do is go through a couple more pages on docs and run some code in Snowflake, but we don't need to do that. It's just some further information around, the tuvaproject.com data marts. This info is all in service categories, which we looked at a little bit, where you can find all the definitions and the specific codes we're using to flag different services. At the bottom, there's also some example SQL. So you can help you get started with, finding out where this stuff is, what the fields are called in the data model if you're not familiar with it, and to do some analyses to get you off and running. So service categories and encounters is the other one. There's some examples here. This documentation is really great to kind of walk you through what is going on and how different things are handled, especially with stitching claims together. And then there's some additional sample SQL at the bottom of this one as well. So yeah, Aaron, I think we've got about 5 minutes left, so want to leave some space for any additional questions. So I think that can wrap up what we were hoping to cover.
Cool, that's awesome, guys. Thanks for going over that. Hopefully that's kind of a 101 intro to what we built with service categories and counters. Had some good questions along the way too. I'll just open it up and don't feel compelled to ask anything, but if anybody has a question about what's been presented or just a general question, or even just a comment around like what you'd like to see us work on next, or the direction, or even feedback about the community, would love to hear from anybody on kind of any of those topics. So we'll just open it up now, but no pressure. Another kind of strength of me and Coco is we're not afraid of things getting awkward. So happy just to sit here on silence for an unlimited amount of time.
So, I mean, Aaron, can you walk us a little bit through the pharmacy, what you need to be loaded, or is it pharmacy on the medical side only? Or you're looking at the pharmacy from the point of sale too?
Yeah, really pharmacy claims data that would go like with medical claim. You know, basically when we think about a claims data set, we think about kind of three pieces of information: medical claims, pharmacy claims, and eligibility. There's also kind of like a medical records pharmacy side of things, which is like kind of the medication orders and medication administrations. But on the claims side, it's really that pharmacy claims. And if you go, Tom, if you wouldn't mind going to the connectors section and go into the Tuva input layer, this is the data dictionary of if you have claims or if you have clinical data, what you need to map to in order to run the rest of the Tuva project. So, and Tom, if you click under claims input into pharmacy claim, this is the information that we're talking about in pharmacy claims. So it's really a table that's at the claim line level. So one record per claim line. A single claim can have and often does have multiple claim lines. And it just has your basic information that you would find on the pharmacy claim about the patient, the dispensing date when it was kind of picked up from a retail pharmacy, who the prescribing provider was, who the dispensing NPI was, what was the NDC code, what was the quantity, et cetera, et cetera.
Okay, so primarily it's going to be claims or the J codes and the corresponding NDCs that come on the medical claims. We're not talking about the point of sale NCPDP claims that come from the PBM, correct? Okay.
Yeah, exactly. At least not right now. Are there J codes that come on pharmacy claims? I thought
they don't come on pharmacy.
They don't? Okay.
Yeah, they're purely NDCs there.
Yeah, I definitely was familiar with those kind of in the medical claims as HCPCS level 2 sort of.
Yeah, that's fine.
Cool. Thanks for the question. Any final
throw
questions?
one out there, Aaron? Joe Worthington here. There's lots of data models, common data models on healthcare, right? So at Snowflake, we are constantly trying to connect these different silos. I haven't looked into this, but there's a lot of popularity for Odyssey OMOP from a clinical observational side. I think it has connections to claims, but has anybody investigated getting the Tuva data model to connect out to OMOP?
Yeah, I mean, actually, before Coco and I started Tuva, we'd kind of like quit our previous jobs and we're like doing some consulting and stuff. And we spent a couple of months like going extremely deep on OMOP. And there's like a couple of things. Basically, what we really wanted to build was this layer of higher level data marts. OMOP's a common data model that's really designed for clinical data and really focused on research. It came out of like FDA kind of like drug safety surveillance. I think it was originally started and funded by the FDA back in 2008. It's currently maintained by Odyssey, is like the larger kind of like nonprofit project. And I think Janssen, which is like Johnson and Johnson's kind of like pharma division, is kind of like the #1 backer of it. It's got great support internationally. Like, you know, in the US and definitely Europe is like hugely into OMOP. The claim, like the support for like claims has definitely been like kind of secondary. I mean, and basically that comes from, it's like originally designed as like, comes from like, you know, very medical record focused type stuff. But I digress. I've got a little bit of, I realize we're at time and I could go on about this for a while, Joe. It's a good question. I'll actually throw like some thoughts in the Slack kind of around the like kind of Tuva OMOP comparison.
Okay.
But yeah, I agree with Adam, just posted a comment. We should make a connector for OMOP into Tuva so that people with their data in OMOP can utilize the higher level Tuva data marts as well. So thanks for the question, Joe. And thanks for everybody for coming. Hopefully this was useful. Thanks Tom and Brad for presenting. I thought it was great and really helpful to kind of get a 101 into how we build service categories and counter groupers. All right, until next time. See you guys.
Thanks, everyone.
Thanks.
Oh, hey, I have a quick comment. I figured out a way to, well, I know the way to edit a Google meeting so you don't have to constantly just omit people. If you'd like to check it out.
Yes, please tell me this.
You can, the way is different depending on if you need to edit a meeting or you're using a new meeting. Do you plan to edit the next community meetup, I suppose?
I just want to use this. My thought, because it was just the easiest thought I had, is just use this link forever and ever for every meeting.
I think then you can edit the original Google meeting then. I don't think you can change it, like change the permissions within the meeting itself, unlike Zoom.
Okay. So like I'll go into the settings and check it out.
Yeah, in the original Google Calendar meeting, if
Cool.
you like edit the settings on there's an option that says join Google Meet. If you click video call options, it should be on the first tab called host controls.
Cool. All right. Thanks for that, Eric. I'll check it out.
You're welcome.
All right.
All right. Thank you.
See you guys.